Equinus, Non-Surgical Management by Patrick A. DeHeer, DPM. Disclosures: I am a principal of IQ Med. I am the inventor of the EQ-IQ brace. The Equinus dilemma: you're not paying enough attention to it. Root said, the worst foot in the world is the one with the fully compensated Equinus deformity. Johnson and Christensen said, Equinus deformity is the most profound causal agent in foot pathomechanics and is frequently linked to common foot pathology. And Hill has stated Equinus deformity is extremely prevalent, and it appears to be a primary causal agent in a significant proportion of foot pathologies. The question becomes, are you evaluating Equinus appropriately, and then are you treating it accordingly? Equinus, non-surgical management. Some of the things we're going to look at in this lecture are: what is stretching, if anything is stretching? How should stretching be done? How long each day should stretching be done? Is manual stretching effective? Are night splints the answer? Should you stretch both legs at the same time? And is there need for maintenance therapy once the deformity has been corrected? What is stretching, muscle or tendon? Abelandia et al. In Journal of Applied Physiology 2009 is an article I'm going to discuss over the next several slides. The present study was to investigate whether changes in the medial gastrocnemius architecture differ between individuals who produce different passive torques during muscle stretching of the plantar flexor muscles, and whether the relative contribution of the muscle and tendon structures to the increase in the total muscle tendon unit lengthening varies among subjects. The study design consisted of 16 healthy subjects with the demographics listed on the slide. The patients were placed prone on the table with both legs extended, and the right foot was strapped to a foot plate for measurement. Leg dominance was not a critical factor, number one. Number two, Manal et al. In Journal of Applied Biomechanics in 2006 showed no difference in pennation angles for various muscles in right and left legs. This brings the question to the forefront: should we be stretching unilateral versus bilateral? For example, if a patient has right heel pain and is being treated for such, should we be stretching the left leg? Because the pennation angle, which is shown on the pictures on the right, both the diagrammatic drawing and the ultrasound study, shows that pennation angles are the same for right or left, and also clinical exams have been shown to be similar between right and left. If the patient has bilateral gastroc equinus and only unilateral symptoms, I do believe that they should be stretched on both sides because both sides are tight, regardless of symptomatology on the unaffected side. Continuing from this 2009 study, the study design looked at the angular displacement of the ankle joint, which was mounted to a foot plate. The ankle angle was successfully rotated from 10 degrees of plantar flexion to 30 degrees dorsiflexion in 10 degree steps at a velocity of 2.5 degrees per second, and the ankle was held at each angle for approximately 20 seconds. The joint angle, passive torque, and EMG activities of the medial gastroc and soleus muscles were recorded over the entire stretch. At the end of the experiment, the subject was asked to perform one maximal isometric voluntary contraction, MVC, of the plantar flexor muscles with the ankle joint at 0 degrees, during which the maximum EMG activity was recorded. Isometric voluntary contracture is depicted on the right. The muscle isometric contracture results in the muscle contracting, but it does not shorten, which is shown on the top picture. Concentric contraction is a typical curl type dumbbell exercise, and eccentric contraction would be the release of the dumbbell as depicted on the bottom picture. So what they were measuring was the top picture contracture. Continuing with this article from 2009, change in muscle architecture, the passive stretching, the medial gastrocnemius length of fascicle increased and the pennation angle decreased when dorsiflexing the ankle joint from negative 10 degrees to plus 30 degrees, resulting in an increased length of the muscle tendon unit. This was similar to other findings from studies listed on this slide. Continuing with the study from 2009, the changes in passive torque and EMG activity during stretching. First, passive torque. The passive torque increased exponentially with an increase in ankle angle from -10 to +30. And the passive stiffness, which was calculated from the slope of the relation between the passive torque and ankle angle between +20 and +30, also is listed 1.02 plus or minus 0.5 meters per degree. The EMG activity during stretching. The EMG of the medial gastroc and soleus were monitored during the stretch and found to indicate relatively little muscle activity. The EMG increased slightly at approximately 30 degrees of dorsiflexion for both the medial gastroc and soleus. Tendon versus muscle lengthening. Compared with the ankle in neutral position at 0 degrees, the total length of the muscle tendon unit of the medial gastroc increased by 5.2% at 30 degrees of dorsiflexion. The change in the length of the muscle tendon unit comprised an estimated relative contribution of 71.8% of the medial gastroc muscular structure and 28.2% by the medial gastroc free tendon. So from their study, they found most of the stretching coming from the muscle, but they did find approximately a fourth of the stretching coming from the tendon itself. This is different from prior studies, possibly due to calculation differences. Herbert et al. In the Journal of Physiology 2002, again looking at the medial gastroc, showed that approximately 75% of the lengthening with stretching was occurring at the muscle tendon unit occurred at the tendon, which is pretty much the opposite of what this study found. Morrison Journal of Physiology in 2008 found a similar contribution of free tendon and muscle length changes in the whole muscle tendon unit lengthening for the medial gastroc. The length of the tendon is greater during the MVC than during passive muscle stretching, suggesting that increasing in the length of the muscle tendon unit during passive stretching occurred before the tendon reached its maximal possible elongation. Continuing from the study of 2009, shows group 1 at 0 degrees, group 2 at 0 degrees, group 1 at 30 degrees, and group 2 at 30 degrees. Group 1, the length of the fascicle was 62.5% with small passive stiffness, which was greater than the length of fascicle of group 2, 37.5% with greater passive stiffness. Group 1 length of tendon elongation was less than group 2 length of tendon elongation. At 30 degrees dorsiflexion passive torque, group 2 is greater than group 1. At 30 degrees of dorsiflexion passive stiffness, group 2 was significantly stronger than group 1. At 0 degrees of dorsiflexion, basically from neutral position, the EMG activity of the medial gastroc, group 2 was noted to be greater than group 1. This was due to tonic reflex activity. And the soleus length of aponeurosis was less than the medial gastroc length of aponeurosis during stretching. This is possibly due to constrained muscle tendon lengthening, and 30 degrees of dorsiflexion of the medial gastroc and soleus showed comparable displacement. Possible structures contributing to limit the myotendinous lengthening. Muscles, connective tissues, endomysium, perimysium, and epimysium. The perimysium is considered a major contributor to passive torque, and this has been shown in other studies. The medial gastroc muscle contains sarcomers that are uniformly distributed along the longitudinal axis of the muscle. An increase in the length of fascicle of approximately 27.5% would induce some resistive force during muscle lengthening, and this has also been shown in other studies that are listed on this slide. Some passive torque during stretching is also generated by the free tendon. Tendon elongation is less during stretching than during MVC, which suggests that the tendon tissues are not a limiting factor of ankle joint dorsiflexion. Again, other studies have found similar findings to this, and the drastic increase in the passive torque for dorsiflexion greater than 20 degrees in group 2 is most likely due to the lengthening of the muscle fascicles and aponeurosis. In conclusion, the present study showed that the increase in passive torque during passive stretching of the plantar flexor muscles is accompanied by a progressive lengthening of both the medial gastroc free tendon and muscle structures, both fascicles and aponeurosis, with the latter showing a greater degree of elongation. The different behaviors among subjects, however, indicate that there is a relative strain of muscle and tendon structures that varies among individuals, and consequently, the relative compliance of these structures influence the muscle tendon unit lengthening differently during passive stretching. How long should stretching be done daily? Bradford et al. In the British Journal of Sports Medicine in 2006 did a meta-analysis, systemic review of the literature to determine whether static calf muscle stretching increases ankle joint dorsiflexion. Their inclusion and exclusion criteria, they looked at randomized or quasi-randomized controlled trials that compared the effect of static calf muscle stretching with no stretching were included. Static stretching was chosen because of its common use. Exclusion were trials that use the other leg as a control. Crossover trials are participants with any neurological disease. Stretching technique that could include either weight-bearing or non-weight-bearing stretches with the knee flexed or extended. Trials evaluating devices to assist the mechanical stretch, for example, splints or pulleys with free weights, were included, but devices designed to assist the muscle's physiological ability to stretch, for example, ultrasound or heat packs, were excluded. Any outcome measures, for example, goniometer or electronic inclinometers, were used to evaluate ankle joint range of motion in both weight-bearing and non-weight-bearing conditions were considered, and measurements were taken during walking or running were also included. 18 papers were identified, 5 trials met the inclusion criteria for review with 161 participants. Ankle joint dorsiflexion was measured both actively and passively, weight-bearing and non-weight-bearing, and with the knee extended and flexed. The duration between stretching and measurement was immediate in all trials except for that of Equinus et al., where the participants were measured between 60 and 72 hours after stretching. 4 trials ensured 100% compliance by supervising the stretches. Equinus et al. Used logbooks instead, showing greater than 95% compliance. All results presented in this review are the effect of stretching alone compared with no stretching. Stretching less than 15 minutes resulted in 2.07 degrees of increased ankle joint dorsiflexion. Stretching between 15 and 30 minutes showed an increase of 3.03 degrees of ankle joint dorsiflexion. And stretching greater than 30 minutes showed an increase in 2.49 degrees of ankle joint dorsiflexion. This result is interesting. It's a little confusing on why the greater than 30 minutes showed less than 15 to 30, but I think some of it's the criteria they use for inclusion and exclusion are primarily inclusion criteria, and some of the multiple ways of measuring and multiple ways of stretching probably influenced this outcome. But clearly these were statistically significant, and if we use 5 degrees of ankle joint dorsiflexion as our barometer for definition, these become impactful numbers. There is a general trend that the longer the stretch, the greater the increase in ankle joint dorsiflexion. The only result that was not supported by the sensitivity analysis was the one for greater than 30 minutes of stretching. As only one trial was included in the sensitivity analysis of this intervention, it may be that the sensitivity analysis sample was underpowered, n equal 45, to detect the effect of the primary analysis detected with greater sample power, n equal 64. Continuing Radford study in 2006. Conclusion: calf muscle stretches provide a small but statistically significant increase in ankle joint dorsiflexion, particularly after 5 to 30 minutes of stretching. However, it is unclear whether the changes that occur with stretching is clinically important. Therefore, calf muscle stretching is recommended where small increases in ankle range of motion is thought to be beneficial. And then this is really what we're talking about with most of our patients clinically. They just need a small amount of increase in ankle joint dorsiflexion to remove the deforming force of the calf onto the foot. Does subtalar joint position matter when it comes to stretching? We talked about subtalar joint position with measurement, but does it matter with stretching? Johnson et al. In Foot and Ankle International 2013 looked at this. The purpose of this study was to determine if individuals with current or recent history of lower extremity chronic conditions and tightness of the gastrocnemius muscle demonstrate more dorsiflexion at the ankle joint / rear foot and less dorsiflexion at the midfoot during the gastrocnemius stretching with the subtalar joint positioned in supination compared to pronation. Materials and methods: they had 27 participants. You can see the distribution. They stretched 5 30-second gastrocnemius stretching trials with the subtalar joint in pronation and supination. Current or recent history of lower extremity chronic conditions associated with limited ankle joint dorsiflexion. of less than 10 degrees ankle joint dorsiflexion with the knee extended were included. You can see the breakdown of the pathologies. Ankle joint dorsiflexion initial measurement on the right side for the patients was 4.6 plus or minus 4.1 degree. On the left side, 4.6 plus or minus 2.9 degrees. Again, look at the similarities between the right and left. So this reinforces bilateral stretching versus unilateral stretching, even if the patient only has pathology on one side and not the other. So again, more reinforcement for bilateral stretching even with unilateral pathology. Continuing Johnson study in 2013, increased midfoot and forefoot dorsiflexion when stretching with the subtalar joint positioned in pronation compared with supination. So with subtalar joint and mid-tarsal joint supination, dorsiflexion occurred primarily at the ankle joint was their finding. With subtalar joint and mid-tarsal joint pronation, dorsiflexion occurred at the ankle joint, the subtalar joint, and the mid-tarsal joint, as we've discussed in prior lectures. Increased ankle joint / rear foot dorsiflexion when stretching with the subtalar joint position in supination compared with pronation was not statistically significant. They were unable to differentiate motion occurring between the ankle and subtalar joint. Maximum knee extension was significantly increased when participants stretched with the subtalar joint in supination compared with pronation. Supination of the subtalar joint results in external tibial rotation. External tibial rotation is required for full knee extension. This is also called the screw home mechanism, and this is what allows for greater knee extension. And this has been shown through several articles. Subtalar joint pronation results in internal tibial rotation, which does not allow the knee to be maintained in full extension when the subtalar joint is in pronation. And this is a critical concept. This is most of the pathology we see is gastroc related, and to accurately stretch it or appropriately stretch it, the knee has to be fully extended. And the only way you can fully extend the knee, as shown by this study, is with the subtalar joint in supination. And this is one of the reasons that patients don't stretch appropriately by themselves, and by using a brace they get a much better stretch. By supinating the subtalar joint, you can externally rotate the tibia, which allows the knee to be locked into full extension if you have a brace that goes above the knee, and then allow for appropriate ankle joint dorsiflexion. Ankle joint / rear foot dorsiflexion increased when the participant stretched with a more extended knee in subtalar joint supination. It was not statistically significant, and it was also the opposite of their hypothesis. The vertical average of ground reactive forces was greater when stretching in supination than pronation. Conclusion: gastrocnemius stretching in pronation resulted in more dorsiflexion at the midfoot and forefoot than stretching in supination. So supination not only is going to allow for more stretch of the ankle itself versus stretching or dorsiflexion coming through the midfoot and rear foot, but it also allows for the knee to be fully extended by externally rotating the tibia. What are the effects of stretching? Macklin et al. In the Foot 2012 looked at the main objective of their study was to establish if there's any evidence for calf stretching as a conservative and safe treatment to increase ankle joint dorsiflexion. While hypothesizing that calf stretching will increase the ankle joint dorsiflexion range of motion, a reduction in forefoot peak plantar pressures and force, but an increase in the heel contact time and overall stance phase time was expected. They looked at 13 runners with an average age of 34. You can see their demographic breakdown. All patients had been injury-free for the prior 2 years. They all had less than 6 degrees ankle joint dorsiflexion with the knee extended. The foot posture index was used between less than +8 to greater than -8. And this is sometimes used to eliminate extreme foot deformity, such as extreme pes planus or pes cavus. Ankle joint range of motion was measured with a goniometer with the subtalar joint in neutral position and full knee extension, and it was measured 3 different times with an average taken of the 3 measurements. Simple adjustable incline platform was used as a bipedal stretching device. A flexor ramp is what they used. The inclined adjustable surface 5 degrees, 10 degrees, 14 degrees, 17 degrees, and 20 degrees. Also, it was used as an ankle joint dorsiflexion measurement tool. F-scan was used to measure the dynamic planar pressures, the ground reactive force, and time variables. All participants were supplied with standardized socks and footwear with a heel height of 1.5 centimeters and a forefoot height of 0.5 centimeters in appropriate sizes. The shoes and socks were only worn by the participants for data collection sessions. So they put everybody in the same shoes, same socks, and they were only worn that one particular time for data collection, and not any other variables were allowed within the study regarding shoes and socks. The patient stood on the flexor ramp for 4 continuous minutes, first thing in the morning and last thing at night. So they stretched for a total of 8 minutes. They recorded it in the diary, the angle of the ramp, the length of time that they stretched, and also made comments regarding comfort. They were evaluated at 4 weeks and 8 weeks. Studies have shown that no statistical significant increase of ankle joint dorsiflexion occurs for at least 6 weeks of stretching. Following 8 weeks of stretching, the ankle joint dorsiflexion increased significantly, with goniometer measurements indicating an average increase of 11 degrees for the left foot and 10 degrees for the right foot. Static ankle joint dorsiflexion increased by over 200% in the study. This is a breakdown of the findings from Macklin's study from the foot, 2012. The left extremity baseline, left extremity 4 weeks, left extremity 8 weeks, right baseline, right 4 weeks, and right 8 weeks. Looking at ankle joint dorsiflexion and the significant improvement you can see on the left went from 5 to 10 to 16 on the left, and from 5 to 10 to 15 on the right. Increased peak plantar pressures at the first and second MPJs for both feet and for the fifth MPJ on the right. This kind of contradicts what you would expect. You would expect to see less peak plantar pressures on these areas with stretching and more pressure being applied to the heel. So why did we see these increase in peak plantar pressures? These findings have led people to question the role of Equinus in diabetic foot ulcers and the role of tendo-Achilles lengthening, as you can see by some articles referenced on this slide. Again, going back to some of the results, you can see the peak plantar pressures under the first metatarsal on the left went from 281 to 351 to 395, and on the right foot went from 397 to 419 to 508. On the second, 464 to 585 to 736, and on the right from 401 to 477 to 621. And then on the fifth, from 216 to 184 to 211, so it decreased on the left side, which was different than all the other measurements. And on the right, it went from 134 to 155 to 195. So continuing Macklin's study, 2012, the early heel off is noted to be a compensation for Equinus, and it's been mentioned by several authors. From this study, the authors expected to show an increase in heel contact time, but instead the results displayed a reduction in contact time. So if you look at the heel contact on the left, went from 0.17 to 0.16 to 0.15, and on the right, similar findings. So it went down a statistically significant amount from baseline to week 8, which is the opposite of what you would expect. So what are some of these variables with peak plantar pressures and heel contact time? Is there an explanation for this? Well, we know with metatarsal joint dorsiflexion resulting in hypermobility of the foot is another form of compensation for Equinus, which has been discussed by several other authors. And the metatarsal joint no longer needs to unlock for such a long period of time, and it assumes normal mechanics of resupination to create a rigid lever effect for toe off. Increase in forefoot peak plantar pressures due to improved gait, which allows reintroduction of the Hicks windlass mechanism during toe off due to improved intrinsic muscle function. And Hicks originally described this in Journal of Anatomy 1954. The foot then becomes a more efficient lever, a rigid lever, by transmitting the energy at toe off. This increases within the ground reactive forces, which will directly produce acceleration, changing the velocity and possibly creating kinetic adaptations, peak plantar pressures. Decrease in time in which the heel was in contact with the ground, and decrease the time of stance phase. From Macklin 2012, some findings from their study. Interestingly, patients verbally reported improved running times as their flexibility increased. With normal ankle joint dorsiflexion, the participant's forefoot peak plantar pressures increased, but the stance phase time decreased. This may be indicating that the duration and location of peak plantar pressure plays a role in creating forefoot pathologies. Although the findings from this study cannot fully explain the mechanism of how improved ankle joint dorsiflexion increased dynamic forefoot peak plantar pressures, it may be possible that the increased dorsiflexion has allowed for more quote-unquote normal foot function. The increased pressures, which are now applied for a shorter period of time over a greater and more even distribution within the foot, may be less harmful to the foot. And finally, these results also strongly indicate that this specific non-invasive stretching regime could be considered before resorting to more invasive options. Methods of stretching. Manual stretching. Why manual stretching fails? Compliance. Most patients are not going to stretch long enough each day, at least 30 minutes per day. Getting somebody to stretch that long per day is very difficult when they have to do it on their own. And there's a lack of follow-through. The literature shows that a minimum of 6 weeks is required. So getting somebody to stretch for 30 minutes a day for 6 continuous weeks, you can see that that would become increasingly difficult from a patient compliance standpoint. And then finally, improper stretching technique. The heel coming off the ground, the knee being bent or not in full extension, or the subtalar joint not in supination. Those technically, to stretch for the gastrocnemius complex is actually very complicated, and to get patients to do it correctly for the correct amount of time every day for at least 6 weeks, your compliance rates go right down the drain. And even in this picture, this is a picture of a runner who's stretching her calf muscle, but if you look at her right heel, you can see it's up off the ground. Even somebody who's an apparent runner in good shape and stretching pretty much accurately here, except for one major flaw with her heel being up off the ground on her right foot. This shows some other examples of poor stretching technique. You can see in this first picture on the left, the patient's knee is bent, his heel's off the ground. This is just a very poor method of stretching. This patient, you can see on the right, is not stretching at all. She's not leaning. She's leaning forward to her hip. There's no stretch coming from the calf whatsoever. Again, we talked about the importance of stretching with the subtalar joint in neutral versus pronated position. And if you have a patient that has a foot like on the right and they don't supinate their foot, or they can't supinate their foot, the amount of stretch is significantly reduced, as well as they're not going to be able to fully extend their knee by externally rotating their tibia. There are other methods of manual stretching, whether it be with a strap like on the left or using a step, and these are fine. These can result in a good stretch. However, the problem is are the patients going to do this stretching for 30 minutes, and are they going to do it for 6 weeks consecutive in a row? I think you'll find the compliance to this goes significantly downward. Why night splints fail? This is a picture on the left of a patient sleeping on their side with a night splint with their knee bent. Most patients sleep with night splints on their side. They're very uncomfortable to sleep on their back, even if they normally sleep on their back. And in fact, studies show that most adults sleep on their sides with their knee bent. When the knee is bent, the gastrocnemius is not being stretched, and the therapeutic benefit is then dampened from stretching significantly. Picture on the right again is another patient sleeping on their side with a dorsal night splint. Again, the problem is with the knee being bent, sleeping on the side, not stretching the gastrocnemius muscle. On the picture on the left, this is a patient just lying on a bed with in a relaxed position. You can see there's still some flexion at the knee. It is very uncomfortable to fully extend the knee to get an accurate or as maximal stretch on the gastrocnemius complex. It's just our relaxed position as a slight flexion of the knee. And on the right is a patient wearing a night splint. Again, you can see if you look at the knee has shown some flexion at the knee. It's not in full extension. Why dorsal night splints fail? I think dorsal night splints are even worse than posterior night splints because they allow the forefoot to plantar flex relative to the rear foot, and you lose a significant amount of stretch in that method. So whether it's a dorsal night splint like on the left or the right, they're even less efficient than the posterior night splints, which are not efficient regardless. The new Equinus solution. is the EQIQ brace. There are several important components to this brace that address the problems of the current products on the market. First, there's an extension along the back that allows the brace to slide up above the knee to allow the knee to be in full extension and lock it in full extension with the straps above and below the knee. Secondly, there is an adjustable dorsiflexion that allows the physician to control the amount of dorsiflexion at each visit. I typically will start the patient off at 0 degrees. I check them back in about a month on their dorsiflexion range of motion, and I'll move them up to about 10 degrees the first month, and then the second month I'll bump them up to about 20 degrees. As the literature shows, it's going to take about at least 6 weeks for dorsiflexion to be where it needs to be. So I will usually can tell patients are going to be wearing the brace for approximately 8 to 12 weeks to get them stretched out adequately. Finally, the toe wedge that goes beneath the hallux engages the windlass mechanism. This is going to supinate the subtalar joint to allow for more stretch occurring through the ankle joint and less through the midfoot and rear foot. Also, as equally important, is it's going to externally rotate the tibia, which allows the knee to lock into full extension via the screw home mechanism, allowing for the most precise stretch on the gastrocnemius soleus complex possible. What is my recommended regime? I recommend the patient stretch for 1 hour a day, seated upright if possible, to also stretch the hamstrings. The literature shows there's a direct relationship between the hamstrings and the gastrosoleal complex and hamstring tightness, as well as conditions like plantar fasciitis. So if you can get the patient to stretch for an hour a day, seated upright, they'll also be stretching their hamstrings as well. I stretch bilateral, simultaneously, even if only one side is symptomatic. For example, if the patient has right heel pain, I'm still stretching the left side. I'm not a big fan of using the brace on the right foot and then using it for a second hour on the left foot. I think your compliance goes way down. I'd much rather stretch both feet at the same time simultaneously for 1 hour a day. Most people can do that, whether at home kind of unwinding for the evening or on their computer watching TV or reading. This is very doable for most people in their hectic, busy schedules that they have on a daily basis. But when you ask somebody to do it for 2 hours, I think the compliance rates go down significantly. So I recommend stretching both legs simultaneously. I recommend checking the patient monthly until they achieve greater than 5 degrees ankle joint dorsiflexion with the knee extended. And if you have a patient that is athletic or high physical lower extremity workload demand, they may need to be placed on a maintenance therapy. So like the picture on the right, somebody who's extremely muscular and calves, runners, weightlifters. I see a lot of military patients, people who are really high demand physical patients. They're going to have a tendency to retighten. So once they get stretched out, I recommend placing them on a maintenance therapy of 1 hour per week. And I suggest making it the same day every week. For example, every Sunday night, I'm going to wear my brace and stretch for 1 hour a day once they get stretched out. And I also think it's wise to go ahead and check them on a periodic basis, maybe every 6 months, to make sure that that's adequate and that you don't need to alter that maintenance program. But that's the maintenance therapy that I use, and I found that's worked well for me over the years. What is stretching, if anything, is stretching? It's a combination of muscle fascicles, aponeurosis, and tendon. How should stretching be done? The subtalar joint should be placed in neutral position, which rotates the tibia externally, allowing for full knee extension. How long each day should stretching be done? Between 15 and 30 minutes according to Radford, but I recommend 1 hour per day until ankle joint dorsiflexion is greater than 5 degrees with the knee extended. Is manual stretching effective? Yes, but it's difficult to do correctly and has poor compliance. Are night splints the answers? Current night splints have flaws, but the EQIQ brace addresses these flaws and provides state-of-the-art Equinus treatment. Should you stretch both legs at the same time? Yes, unilateral stretching can result in functional limb length inequality, resulting in hip and back pathologies. Is there need for maintenance therapy once the deformity has been corrected? Yes, in high-demand patients. Any questions, please feel free to email me at PADeHeer@sbcglobal.net.